So, good morning. So, today we are going into the topic testicular torsion. So, the testicular torsion topic is very important when it comes to your Viva examination. So, whichever Viva you're attending, whether it's a man Viva, whether it's a MOH Viva, whether it's for DHA, every topic, everywhere, this testicular torsion question is very important. So let's get into the topic proper. So I'll be discussing this topic as if we are discussing a regular case. So, for example, how this comes to work. So, first thing is whenever a patient comes to you, there will be like the scenario will be given. Like the examiner will be the patient, and you would have to take the history proper from this patient. Okay, so this is how you need to proceed when it comes to the question. Okay, so first of all, let it be a child of 16-year-old. He came with the complaint of pain over his lower abdomen. So this will be the scenario that the patient is coming to you, or it could be like a small baby with who is coming with excessive cry. So there will be no history of any pain or anything. Nothing will be said. Just the baby is having this cry, excessive cry. So you would have to completely examine the patient from head to toe and reach up to the testis level, and then find out that this is a testicular torsion. So there will be no hints. Nothing will be given at that point of time. Okay, so this will be scenarios that people will come to you, and then they will actually give you the ideas, and you would have to actually go in a proper manner, that is in a step by step manner, from which you can actually identify what kind of a patient that is, or what is the diagnosis. So this is how you need to proceed. Okay, so for example, I've already given an example. This could be like a patient is coming to you like with history of like lower abdominal pain, and you would have to elicit all the examination. You have to look for the gentle examination and then find out that this is a testicular torsion. Okay, otherwise it will be a baby with excessive cry saying that he have pain, he have been crying for more than like 3 or 4 hours directly straight, and we don't know actually what the baby is crying for. So the parents are like panic, and they are bringing their baby to you. Or else this could be like a patient is having saying that this patient is having some kind of a pain over the testicular region, but he may not give you he will not give you a correct history, and you would have to elicit and come to a point that it is a testicular torsion. Okay, okay. So now let's get started with the testicular torsion topic. Okay, so for the introduction, I'm saying that this is definition is like testicular torsion is a surgical emergency caused by twisting of the spermatic cord, leading to the compromised blood flow to the testis. So actually what is happening is the spermatic cord is getting like it is getting twisted. Okay, so what happens is the blood flow to the testis is cut off at that point, and this creates pain to the patient. Okay, so why this happens, you may already have read about it may be like congenital things, congenital problems may cause this testicular torsion. Okay, and also you don't have to be more like in depth of this anatomical thing, but you need to know why it is happening. It may be due to that the genetical issue. You need to know about that. Okay, congenital issue which is causing this testicular torsion. So you need to actually know why this is happening. So for that you need to know that. Then about the epidemiology, you need to know that it will come in like the males. More probably it is common in males aged between 12 to 18 years old. Okay, incidence is 1 in 1000 males. Okay, it is most probably seen in 1000 males under 25 years annually. But it is not necessary that it is not seen in children. It is also seen in children. Also, it is not necessary that it's always 12 to 18 years. Okay, next is about the history taking. This is an important part when it comes to your Viva, because you need to take the clear history. Since this is the first presentation, it will be in pain. The patient is coming in pain. You have to follow the SOC or ATES Socrates. You have to ask for site of pain, onset of pain, character, radiating factor, associated factor, okay, trauma, and all other symptoms associated with it. You have to ask for the elevating and exaggerating factors. You have to ask for everything. So you have to move by the Socrates method, and you ask for the sites. The patient will say that it is in lower abdomen, or he may directly say that it is in the scrotum. Onset is important in case of this thing, because torsion, because 6 hours is the maximum from the onset of pain that you can actually say that the testis is viable. After that, there is no role in surgery also. It may lead to the complete death of the organ. So you need to know the time period is very important in case of this testicular torsion. Next, C is the character. Character is what kind of a pain it is. It is dull, aching, or what kind of a pain it is. You can ask anything radiating. Is there any radiation to abdomen or radiation to any other areas? Okay, did he take any medicines, and that did that actually help him, or any change in his position is helping him, or anything associated with that. And you should ask for the associated symptoms as well. Okay, so you can see here presenting complaints will be sudden onset of severe scrotal pain. It will be often unilateral. That is an important factor, because in case of infections or any other symptoms, it will be most probably bilateral. If it is an unilateral pain, it's more probably pointing towards a scrotal pain, which is causing this torsion. Okay, it may radiate into the abdomen or the groin area. So the duration pains typically last less than 6 hours in acute cases. So 6 hours is an important time period or time lapse in this case. Next is associated symptoms. So you need to ask whether the patient is having any nausea, vomiting, or any other symptoms along with this presenting complaint. Then you should ask for the urinary symptoms. It helps you to differentiate between epididymitis. So in case of infection, the patient will may also say that he have pain during menstruation, or is having fever or any other symptoms, but that will be most probably absent in case of an testicular torsion. Okay, next is past medical history. You should ask for the past medical history of the patient. If he already had an episode of scrotal pain and then resolved, or he have any history of testicular torsion in the past. Okay, that is an important thing that you need to think about. And also you should ask for the history of trauma, because sudden trauma can cause distortion or vigorous activity in past few days. Vigorous inactivity of testes, that can also cause some kind of testicular torsion in some cases. So you need to also ask about those history. Okay, then your this is also runs in family, so you need to ask for the family history of cryptorchidism or testicular torsion that is prevalent in his family, whether that was there in his family. You should also take the family history. So you already took a clear history, so never forget any of this main important stuff. And also you need to ask about this Socrates method. And also while you're examining a patient having a pain, you need to ask the patient to scale the pain from 10 the least, I mean 1 the least and 10 the most. So from 1 to 10, how he will scale the pain, because if he's having a very high pain like more than 7, or if it is a severe pain, it is better that you give them a like pain management even before taking a history. You can start with a pain management. So you can ask whether he needs some pain medications before taking the history proper, whether he want to be more comfortable while taking the history. So that will help you a lot. Okay, so that thing also you can do. So you need to first of all scale the patient's pain, and then you can give the starting more medications also. If we're saying like 7, 8, 9, then opioids may be when opioids may be needed. And if saying just it is 3 or 1, 2, then it's just paracetamol or any kind of NSAID will work. Other sign in between somewhere, then IV medications it may be necessary. So you have to grade the pain also before completing this history. Okay, you have come into a point where you have taken the history. Now it will be the physical examination. Okay, in the physical examination you will look for the general examination. So here, if I have missed some point, you can add like surgical history, past drug history, any history. Surgical history is important. You have have undergone any histories. So all that history, what you regularly take in case of a medicine or a surgery case, you have to add it over here. Okay. Okay, then. Okay, so physical examination. In physical examination, first thing that you will look for the general examination, how the patient is in distress, or he's guarding due to pain, or he's touching touching that area repeatedly because of pain, or what is happening exactly. What is that you get from a general examination? Generally, how he is looking. Also, take the vitals of the patient. Okay, you do all of that, and then you will go for the inspection of the scrotum proper. You're going to examine the scrotum proper. So in this case, if the patient is saying that his pain is abdominal pain, you will start the examination with the abdominal pain, and then you reach the scrotum, and then you start examining the scrotum. Okay, if it is a baby crying and you don't know what is happening to the baby, then it will start from head to foot examination. You will palpate all over his head to see whether there is any traumatic injury that has happened to his head. Then you will examine his ears to see whether it's leaking any kind of discharges from the ears, which is acute otitis or anything of that sort. You will go for his nose to see whether there is any foreign bodies or something like that. Then his mouth to see whether there is any infection or is there anything that is blocking over there. You will examine the oral cavity, and also then you will go to the throat of the baby, and then chest, abdomen, and then you will reach the scrotum of the baby. Okay, this is how actually in case of abdominal colic also, baby will cry more when you press the abdomen. So then you will reach the scrotum, and then scrotum, the baby is crying more, then it will reach, you will reach into a conclusion that it's a testicular torsion. This is how you need to evaluate a patient. So this is how you have to progress. Okay, so now I'll say about the local examination of the scrotum. Inspection, you will look at the swollen, whether it's swollen and erythematous, and tender scrotum will be tender. It will be swollen, erythematous, and also the tender scrotum will be tender. Okay, next is high riding testis. Testis will be in a different position when compared to the other testis. So you will see a high riding testis. Then you will see a palpation. You have actually palpate and say what is happening. So you will see tender testis. And there is testis as tender and firm to touch. It will be not soft, it will be very firm. And the absent cremasteric reflex, you will see, that is, you stroke through the inner thigh, there will be no elevation in the affected side of the testis. Okay, other sign that you can do is negative friend sign, because this friend sign is important because it will actually help you to differentiate between infection and this testicular torsion. Because infection, case of infection, this pain will be elevated while you elevate the testis upward. So in case of this test, friend sign will be positive in case of infection, but in case of epidermoorchitis, it will be negative. Okay, next thing is about systemic examination. While you do the systemic examination, what you will see is check for the fever or any other symptoms and signs. Okay, usually it will be absent in case of testicular torsion, while in case of infection there will be symptoms like fever and chills, because this patient is having infection. Okay, next is investigation. What you can do is do a urine analysis bedside, because it will help you. It will be normal in case of torsion. It will be high in case of, there will be muscles in case of an infection. So to rule out that, you can do a rule of infection, you can do the urine analysis. Then the gold standard is Doppler ultrasound. You have to see the ultrasound of the patient's testis. Reduced or absent blood flow to the affected testis confirms the diagnosis. Okay. Then blood test is not usually required, but you can do CBC. And if a patient is having, is you suppose this patient is having this testicular torsion and he have to undergo a surgery, then you can do the complete surgical workup for the patient. Okay, next is the diagnosis. So the diagnosis is basically clinical diagnosis, because that is why this comes in an exam also, because this is a major clinical diagnosis. It's based on history and physical examination that you find out that this person is having testicular torsion. So imaging is just a confirmation of your diagnosis. Okay, everything comes from the history and physical examination. So the imaging confirms what confirmation with the Doppler ultrasound. If clinical uncertainty is existing, then only this is needed. But still, we will do that. We'll still do that. But in case of your examiner may say that there is no ultrasound facility at your center. In that case, you should immediately say that I will refer this patient to a surgeon so that he needs an exploratory surgery as soon as possible, so to revert this torsion or kidopexy. That is what we say. So for that, I need to actually refer the patient as soon as possible within 6 hours. So that answer is what the patient that the your examiner is looking for. So you have to say that. Next is differential diagnosis. They may ask about differential diagnosis, so you can say it is epididymitis, epididymo-orchitis, torsion of the testicular appendage, and inguinal hernia. And you should also know how to differentiate all of this. As I have already said, in case of infection, there will be the front sign will be positive, and also there will be urine analysis will show pusses, and also the patient may have fever. All of this will be negative in case of testicular torsion of testicular appendage. There will be a blue dot sign in case of torsion of testicular appendage. And also inguinal hernia, you will also look for the hernial orifices, and you will ask patient for the cuff reflex and everything, and you will see whether there is any kind of a bulging over the area, and if there anything is slipping downwards. So that examination will actually help you find out that is not an inguinal hernia and this is a testicular torsion. So you can also they can also ask how would you differentiate that this is not epididymo-orchitis or this is not inguinal hernia. So this is how you actually differentiate each of them. Okay, next let's go into the management. So the goal is to restore the blood flow to the testis. We know that that spermatic cord is twisted, so that the blood is not flowing anymore to the testis. So what we need to do that we need to actually restore the blood flow to the testis to prevent the irreversible damage. Okay. So immediate management will be actually keeping the patient NPO, nothing by mouth, in preparation for surgery. So we need to prepare the patient for surgery. So then analgesia of pain relief. So most probably a patient will have severe pain, and we will have to give IV analgesics. Then manual detorsion. You can try manual detorsion like open book. Opening it's like rotate the testis outward, opening book, but performed this surgery is delayed, but you can try. But the success indicator is pain relief. If the patient is having pain relief and improved blood flow, then that is a success. But it is better to go for a surgery, because that is the thing that will actually prevent this reoccurrence of the surgery. Okay, surgical management is definitely treatment is orchidopexy, orchidectomy. Orchidopexy is means fixing the fixing the testis to prevent torsion by itself. So that will be what we do with orchidopexy. So orchidopexy is not just done on the side affected, it is also done in the contralateral side, because this patient is prone for torsion. Okay, this patient is prone for torsion. He can have the torsion after a few months or after a year or whenever he is more prone for torsion. So if you know that, to prevent that, we do a contralateral testis, the orchidopexy as well. Okay, to prevent that in future. Then we do orchidectomy. Orchidectomy is done when the testis is completely ischemic. There is no use of testis anymore, and the testis is completely ischemic. The blood flow is completely cut off, and in that case, you would have to do orchidectomy. If it is unsalvageable, only we do this orchidectomy. Okay, surgery within 6 hours ensures more than 90% of testicular salvage. Delays beyond 12 hours significantly reduce salvageable rate. Okay, so this is based on the level of ischemia that you decide whether to go for an orchidectomy or not, but within 6 hours is the most better option in this case. Okay, Now, post-operative care will be like pain management. You will continue the analgesics as needed, and also you give antibiotic to the patient to remove to prevent secondary infection, and also follow up after a few months to look for the complications like atrophy or infertility. Okay. Okay. Complications of this complications. What will be the complications? Okay, so let's say what will be the complication. I'm saying the complication will be testicular atrophy, and due to delayed intervention, then infertility, potential risk of bilateral torsion occurs, potential risk if bilateral torsion occurs, then psychological impact like anxiety related to testicular loss. So this is a major complication, atrophy or infertility, and psychological impact. So you also need to look to that. Okay. Next is uh, how to prevent. So preventers educate the patient and family on the importance of seeking immediate care for scrotal pain, prophylactic orchidopexy in individuals with a history of intermittent torsion or congenital anomalies like Bell-Casper's deformity. Okay. So this is what congenital anomaly that I've already talked about. So there will be something like bell clappers deformity, which is actually making this patient have the torsion. Okay. Uh, okay. So these are the things that you need to actually educate the patient about. So thank you so much. So I think we have already covered this topic in detail. So this is a basic thing that you need to know about testicular torsion, and it's very important topic when it comes to like when it comes to your Viva as well as your regular theory exam. So yeah, we'll be discussing other topic the way through. Okay, thank you so much.